Good morning, Dr. Layne. Thank you so much for taking the time to come on and chat with me. I'm really excited to have you here. So welcome.
Thanks so much for having me. It's an honor.
Yeah, absolutely. I was so excited to have met you at the Greater New York Dental Meeting and to be able to hear your story. I mean, you can feel your emotion as you're telling the story, and I'm sure your patients feel the same way. They feel the love. You care about your patients. So tell us a little bit about how you made that transition from more traditional restorative dentistry to airway.
So I actually was in the Navy. I got out of the Navy, started a practice from scratch, and had the opportunity to train with Larry Rosenthal. And Larry is one of the most amazing educators I've ever seen. I learned so much about doing veneers. And after training with Larry, I ended up training with John Cloyce. So I really had my restorative practice at a whole other level, ended up joining a pros practice. And I also was in a Cloyce study group for mentors in the New York area, which is really the reason I became a mentor. A lot of the guys I looked up to at Cloyce were in this study group. And a guy in the group is Victor Avis, who every time we would discuss a complex case, he's like, I bet you the person has an airway issue. And I'm like, whatever. And he would always say it. And I'm like, Vic, I'm a veneer guy. I do crown and bridge. You know, like I open up vertical. This is what I do. I'm airway sleep. Like after the 50th time, I'm like, all right, teach me about it. And he told me about it. And he trained with Barry Raphael, who's an integrative orthodontist and airway specialist. And I went to train with Barry, and I realized that everything that I was seeing every day in my dental practice, so broken teeth, severe wear, high vaulted palate, cross bites, large tori, were all the signs of an airway problem. And I missed it for 15 years. And it sucked because now I was like, oh my God, all these patients with wear, anterior wear, an airway problem. So that was kind of how I got into it. Victor is the reason I got into it. It's like a blessing and a curse.
Yeah.
Because I was like on a good road, somewhat on a good road to just make a great living, do what I was doing.
Yeah. And, you know, it's funny. I think we all kind of feel that initial kind of guilt, right? Like I remember sitting in my first myofunctional therapy class and being like, how many patients like went to my chair where I totally missed, you know, the tongue tie, the airway issue, the crowded teeth, or whatever. I think we all feel that initial like, oh crap. But you know, you have to look on the bright side of it. Now we know it. We can never unsee it, unknow it. And the amount of lives that we can impact moving forward is tremendous.
Absolutely. Now, and that's great. And that's a great point because when I lectured at the Greater New York and I got choked up, like I miss those things. And those guys aren't here.
Right.
And that's the problem we face.
Right.
Because if it was happening in my chair, it's happening in every dental chair in the country.
1,000%. Now,
and that's the message.
If you don't mind, would you mind sharing that story again? We don't have to.
Yeah,
I mean, I know it's super tough for you, but I think it's important that listeners hear it because it's the reality of it, right? We all at some point have come close to this.
Yeah. So, getting forward, I sold my dental practice and I went back to ortho because I figured that ortho was a way to fix the problem. While in my ortho program, I got a call that a patient of ours, Ron, passed away. And Ron was a friend. I knew him well. He died of heart failure. And the issue was, I knew he had sleep apnea. He was in my chair. I knew he had it, right? He had wear. He had broken down dentition, collapsed vertical. He snored. He had high blood pressure. He had acid reflux. At that point, I was somewhat versed in airways. So I was like, Ron, you need a sleep test, right? Like go see a physician. He didn't go. and now he's gone.
Mm-hmm.
So, but 6 months ago, I was running in Florida.
Mm-hmm.
I get back to my hotel. A buddy calls me. He's like, Dave Duffy died. I'm like, what the hell are you talking about? 40,
Mm-hmm.
2 kids, same thing as my buddy Ron. He snored. He had high blood pressure. He had acid reflux, broken teeth, worn down dish, and collapsed vertical. And both guys, I fixed their teeth and I fixed their vertical. So I missed it.
Mm-hmm.
Right now, granted, they had other comorbidities and their physicians probably should have picked up on it, but I knew they had it.
Mm-hmm.
And, you know, it was like not enough that I became a diplomat of the American Board of Dental Sleep Medicine after I heard my buddy Ron passed away, because I was like, all right, I really need to start spreading the message.
Mm-hmm.
When I heard my buddy Dave passed away, I was like, this has to go beyond dentistry. And that's really the message, because, you know, in medicine, just like dentistry, we fix symptoms, right? Someone has high blood pressure, just keep throwing meds at it until it goes away. But why does the person have high blood pressure? Or why does that person have AFib? Or why is someone breaking a teeth? You know, why are they breaking teeth? And, you know, it's interesting. I just got asked to do a talk for the New York County Dental Society. And my talk is, why did my beautiful veneers and crowns fail?
Mm-hmm.
Because they all did.
Right.
You know, and that's the problem. Like, I did dentistry at the highest level you can do it, and they were still failing.
Right.
Because I missed the root cause problem.
Yeah. And, you know, I actually am going through this with my father right now, because my dad, I knew he had sleep apnea. I finally got him to take a sleep test with one of our local doctors. She has a home sleep test. So I actually had to lie to my dad to take it. I was like, listen, I got this from Sky. If you don't take this test tonight, they are going to charge me double. They have to get it back. And so he finally took it, because he's like, well, Britt, I'm going to kill you. I don't want you to get charged. So now I have to take this stupid thing. And I'm like, all right, Dad, whatever. So he takes it, comes back moderate OSA. And he's like, nope. He's like, I barely slept that night. That it doesn't know what it's talking about. I don't believe it. And I'm like, fine, then we'll do an in-lab study. So I send him to the sleep physician I work with. He gets an in-lab study, comes back mild sleep apnea. He tells me, now I find this very hard to believe. I'm still this like literally just happened. So I'm still trying to get in touch with his doctor. Now, my father is the guy that has the pill box. The amount of medications this man is on, so many comorbidities. And he claims that his doctor told him he doesn't have to do anything about it. And I'm like, Dad, do you know what having sleep apnea means? Like, do you actually know what happens to you in the middle of the night? And he's like, I don't think I actually stopped breathing. And I'm like, yes, you do. I'm like, you literally took this test and it is telling you how many times in an hour you're stopping to breathe. So that's going to be my actually Sunday. My family's coming over for Christmas cookies. And the sleep physician that I work with, I'm pretty close with him, and I'm going to FaceTime him while I have my father with me, because, you know, as his daughter, he thinks, oh, you think you're a doctor? I'm like, well, no, I don't think I'm a doctor, but I would consider myself like a specialist in the myofunctional airway space for sure. So it's very frustrating, but the amount of times it gets missed, and my dad should have had this sleep test done years ago. If I ever showed you his medical history, you'd be like, without even knowing, you'd be able to tell he snores, the whole thing.
Yeah. So there's so many parts to this. The issue at night for people that come in with multiple meds for hypertension, AFib, the cardiovascular, the problem is they're going into fight or flight all night. So what happens is their heart rate goes up and their blood pressure goes up, and then it goes down and then it goes up. So it's putting a ton of pressure on someone's heart. So, you know, I don't love AHI, to be honest with you, because I think the metric is screwed up. I think that you have dogs, right? Like my AHI was 4. But I snore. I was tired. I was needing coffee at 5 o'clock.
Right.
So the analogy is, if you have a dog and the dog wakes you up 4 times an hour and you sleep for 6 hours and you get woken up 24 times a night, are you not going to be exhausted?
Right.
So to me, I don't look at AHI, I don't look at sleep apnea, I look at airway. The other part of it is, as a dental team, as a hygienist, as a front desk person, as a dentist, I don't need a sleep test to know if someone has an airway problem. If they have wear on their front teeth and they don't bite pens or they don't have a parafunctional habit, they have an airway problem. Right? And the problem is, we see those things every day. Now, from an orthodontic standpoint, I look at faces and I can tell if someone has an airway problem. Do they have a retreated chin, retreated maxilla? You know, their chin throat length is a certain way, their nasolabial angle. So I'm going into offices now, you know, Michael Gelb and I are partners, and we're teaching dentists to look like the office manager. I'm like, I want you to look at faces and let the doctor and the team know, you know what, I think Mrs. Jones might have a problem.
Yes.
Right. And that's the thing. So I don't need to take a 10-week course. And I've done it. I've gone down every rabbit hole and airway and sleep you can go down. But to me, we're teaching dentists in 3 or 4 hours, and their team, wear on front teeth, high vaulted palate, crossbite, airway problem. Then we're telling every single hygienist and dentist, give them a disposable home sleep apnea test, because we screen for blood pressure. You screen for oral cancer, screen for airway. Right. And our physicians love it that we're given. I mean, we're not stepping on their toes because they're still doing the reads. They're doing the letter of medical necessity. But I want to know. And the fact is, it is a cover your ass kind of protocol. But like, you probably knew your dad had an airway issue, right? And that's the thing, where we want to look at people and really address the problem. And that's where dentistry and ortho is such a huge part of it. You know, like I said, people like Ben, Barry Rayfield, Bill Hanks, they're fixing the problem and not just the symptom.
And I love how you said that. I mean, I think, you know, there's a time and place for everything, and oral appliance, you know, therapy is great if it's going to help the patient at night, but it's not fixing the root cause. And then they're going around all day, probably still in sympathetic overdrive because they can't breathe. And,
absolutely.
You know, so let's talk a little bit about, like, what is your take on oral appliance therapy?
So it's a great question. I've been trained. I worked in the NT office. I did tons of oral appliances. I think it's a great adjunct. But like I said in my talk, I had a 25-year-old guy that we gave an oral appliance to. Like, how? And he asked me, he was like, do I have to wear this for the rest of my life? Like, how is that acceptable to give a 25-year-old an adjunct for 70 years? So ortho is a way to fix that problem and really grow the airway and help the anatomy. Now, there's other things. There's Inspire, you know, there's surgical procedures. Ortho is really a great way. Now, the other part of it, though, is I'm a huge believer in starting someone out with oral appliance, because I want to prove that they're going to get better, right? And not only that, I'm a huge believer in combination therapy. I was taught, John Remmers taught me at Tufts, and I'm a believer in CPAP. And I'm a believer in combination therapy because I want their pressure to be low. I always ask people that come in that are on CPAP, like, what's the pressure of your CPAP? Most of them don't know, but I would love for it to be between, you know, below 10, you know, centimeters of water pressure. Because more than that, it's almost like someone's having a leaf blower in your face. So, but what the beauty of working with Michael is, Michael uses his lower Gelb appliance. So it's a repositioner. It brings the mandible down and forward. We do that with bite block therapy and ortho for class 2 cases. So the issue is, and you brought up a point, like, during the day, are they going into sympathetic overdrive? Is their mandible dropping back? The appliance that Michael and I created, it's 2-in-1. It's a repositioner. They could wear the lower part during the day that has cuspid guidance. It keeps their mandible forward. And then at night, it's just an upper piece that prevents their mandible from falling back. And the other thing is, all dentists that don't know about oral appliance and sleep, they're going to be like, oh, the bite's going to change. Who gives a shit about the damn bite? I spent 15 years looking at the bite. And you know what? It got me nowhere.
Yep.
and I probably made a lot of those people worse.
Mhm.
So the other thing is the beauty of oral appliance therapy. If there's dentists that are watching that are doing ortho, sometimes if you take a skeletal class 2 patient and you put them in an oral appliance, what's going to happen? They're going to come down and forward.
Mhm.
A lot of them are going to end up with a posterior open bite.
Right.
And that's the conversation you have with the patient prior to be like, you know what, Mrs. Jones, we're going to get you feeling better,
Mhm.
but let's fix the problem. And you can do it obviously with restorative dentistry and
Mhm.
build up the posterior teeth,
Mhm.
or with ortho. The point is that no one walks into a dental office. I don't know if Michael addressed this, but we always talk about it. No one walks in and says, I have an airway problem, right? They come in because they're like, my jaw hurts,
Right.
or I have broken teeth.
Yep.
So we want to get them out of pain. We want to get them sleeping better, prove the concept, and then put them into ortho. And that's why, like I said, people like Ben, Barry, Bill, our program, we're doing ortho to fix the problem.
Right. And talking about Dr. Gelb, I love that slide. And I always talk about this slide that he brings up where he has the two pyramids with the paradigms of like old dentistry and airway dentistry, and how teeth should be the first thing that you're trained to look at, and now teeth should be the last thing. So to your point, who cares about the bite? I mean, if you're getting their airway open and they're feeling so much better, then you can address it. 1,000%. Now, there was an ENT that came to the Greater New York Dental Meeting, and you were speaking to him at the end.
Very nice guy. Yep.
Oh, he's so great. So I met him on Instagram actually, and he wanted to know more about myofunctional therapy. So we had a chat one night, and I was like, listen, there's a whole airway summit in New York. You live in the city, come and check it out. And he did. But so some of the questions I know he had asked both of us, like he was saying how he gives Botox a lot for patients that, clench and grind their teeth. And he was wondering, do you think that that's harming them more? Because we know what the masseters, the whole protective mechanism, the idea of the clenching and working those masseters to help open the airway. So what was your response to him with that question?
I think I'm in favor of it. Obviously, I wouldn't want it abused, and I don't want someone to have to rely on it, because you're still fixing a symptom, right? The patient's still coming in, like, why do they have that masseter pain, and why are they clenching and grinding? And that was actually the second part of my topic at the New York County Dental is it clenching, grinding, or airway? It's probably all three. And, what came first, the chicken or the egg? Like, did the TMJ problem cause the airway problem, or did the airway problem cause the TMJ problem? So to me, a question I always ask Michael Gelb is, because no one's better. I mean, I've learned so much from Michael. He's like the guru on TMJ. No one is better about TMJ in the world than Michael Gelb. And I've learned so much from him. But I asked Michael an interesting question. I said, do you think people can clench and grind in centric relation? So rearmost, uppermost. So, which I spent 15 years of my career putting people in CR. No one should even talk about centric relation. That should be a term that shouldn't even be in dentistry, because you're pushing the mandible back, you're closing the airway. The other thing I realized as a restorative dentist, when I opened up vertical, and I didn't realize this until I was in my ortho program, your mandible is on it's a hinge, your jaw. So your mandible rotates clockwise. So when you open up vertical and you don't reposition someone forward, their mandible goes back.
Right.
And I learned this the hard way, because I used to finish cases with anterior open bites because I wanted them to have a freedom to chew. And a number of patients that I ended up leaving them with a little bit of an anterior open bite, 6 months later, I would take shim stock or articulating paper, and they were closed back down. And I was like, what the hell happened? They were posturing their jaw forward to open up their airway. They were doing CPR on themselves. And that's the message that I tell every dentist. You see wear on someone's front teeth, airway problem.
Yeah.
So I think that, to your question, I have no problem doing Botox on masseters. Masseters a lot of times in women, temporal tendonitis a lot of times in men. You're relieving a symptom. you're still not addressing the root cause of the problem, which is probably an airway problem. And that's probably why they're clenching and grinding.
Now, so you are finished in this summer, right? With your program?
This winter, probably. Like
Oh,
we're
this
going,
winter.
our program's going through accreditation. It's brilliant. Our director is like the smartest guy I've ever met. Like people, we sit in a room with him, and I think all of us are just looking around being like, you know, he's so brilliant, because even in my mouth now, like I'm in ortho, but I'm in sectional appliances. I have what's called an anterior V-bend. The biomechanics are very different. So we look a lot at molecular biology. We look a lot at biomechanics. We look a lot at what's called, you know, moments and couples of how kind of things move. I became a physicist and a biomechanical engineer at the age of 45. I was like, I thought I was done with physics. And now I'm back in school like that. Yeah.
So if I had to ask you, like, what do you envision your perfect dental practice to look like? Like, what kind of patients would you treat? How would you treat them?
So, you know, that's a great question. You know, it's funny. I was like looking at the questions. I kind of printed it out, and I wanted to talk about that. So the interesting thing is, I didn't even think I was going back into practice. I really went, I sold my restorative dental practice, and I wanted to go teach. Like that's what I wanted to do. And I really got into ortho because I knew I wanted to like spread the word, and I thought it was great credibility to have it. Now, I didn't realize that my program would be this forward thinking. Not only that, for the last 2.5 years, they've listened to me harass the shit out of them about airway. And they are they're the only, so I'm faculty at the program now. And now we have an airway and TMD curriculum at the ortho program. That's like the only ortho program in the country that is implementing that. Yeah. And myofunctional therapy. They're all about myofunctional therapy because they realize soft tissue, right? We're seeing orthodontic surgeries that relapse. So the perfect dental practice, I think if it was me, or if it was like my little cousin just graduated dental school, I would tell him, you know, look at airway, start treatment planning, not like I did, because as a Coist dentist, it was always perio, biomechanics, function, aesthetics. Look at airway first. I want the dentist to still do restorative dentistry, right? The patient that comes in with the worn down dentition, they still need restorative dentistry. It's just a matter of setting the case up so it doesn't fail, because I had so many failures and I didn't know why. And it was too late when I kind of got into airway. So I think it's more about like looking at root cause. To me, that's where I think we're going. Functional medicine is taking off. And I think functional dentistry is going to kind of be the next wave. And I think, you know, people like Michael Gelb, Jeff Horowitz, myself, like we've really thought about this, about like, maybe we don't have to drill down teeth, right? Like maybe it shouldn't even be about teeth. Maybe it should be about looking at airway, looking at health. Like, I don't want to cut down veneers and crowns. I mean, I made a great living doing it, but like a lot of those people probably didn't necessarily need it, or that type of aggressive dentistry. Or, you know, you brought up a point before about like clenching, grinding. Our teeth should touch for 20 minutes a day. I always say this to dentists: you have to breathe for 1,440 minutes a day. Like that should probably trump what the teeth should do.
1,000%. Now, if you were well, actually, let me ask you this question first. Do you think, or maybe this is your mission, so the ortho program that you're in, it's very heavily focused on airway, thanks to yourself. Is it like your mission to then go and spread that to other ortho programs? Because they all need it, as we both know.
So I would love that. So, you know, Michael and I, and Jen Kirkham, who's a former hygienist, we started a company, and, you know, we work with Ben and Lauren, and it's really more about like looking at TMJ, airway, ortho, right? Because those are the things that really are the problem. Now, my ortho program, they're really on board and supporting us, which is amazing, right? Like what an accredited ortho program, you know,
Right.
it will, hopefully, God willing, it'll be accredited. And what we're doing is we're doing a curriculum there. We're doing an airway center that we're going to do appliances and then feed a lot of those patients into the ortho school. So people come in, we'll market it as, are you having airway issues, snoring, sleep apnea? We're going to home sleep test them. We have our physician. I even want to do the carotid ultrasounds there for people that are really high risk. The other part of it is we have a whole continuum we're setting up. I have a meeting tomorrow with our director to train every general dentist in ortho, and no ortho program has that, because I think they realize that there's so many general dentists that are doing orthodontics. And the problem is so much of what we do with clear aligners, with just brackets and wires, we're closing off airways. Every time you do IPR, you close someone's airway off. And I don't think, a lot of dentists don't understand that. So would I try to spread the message to other orthodontists? I sit and listen to Michael all the time, and Michael is a disruptor. And I've never been a disruptor, right? I've run the straight and narrow, Navy, Larry, Coyce. I've spoken to a lot of orthodontists and they just don't get it. And I see some incredible restorative and general dentists doing amazing orthodontics, right? No bicuspid extraction, no IPR, no retruding, everything expansion, everything uprighting. So that's a tough question, because I really try to defend our specialty, and it has such an amazing opportunity. I just feel like a lot of people, it's just about straightening teeth and they're missing it.
Now, when you are talking to an orthodontist and you're trying to explain to them your stance, do you have a certain way that you tend to approach it? I don't want to say you have a spiel, because that sounds like, you know what I mean? But kind of you try to, you have to say something to them that's going to catch their attention, right? Otherwise it's going to be in one ear, out the other. Yeah, airway. Okay.
So it's not even a spiel. I asked the question to a group of orthodontists that I know, right? I saw a patient that had an anterior open bite, and they had wear on their ones, their central incisors. No parafunctional habits. They didn't bite their nails. And I asked them all, I said, tell me why that person has wear on their front teeth. And they all sat around. And I said, when's the last time you guys took CPR? That person is posturing forward to open up their airway. So all these people that are class 2 that get corrected, and you don't address soft tissue, right? Because that's a big part of it.
Oh, yeah.
So many of those people relapse. That's the thing. All the adults that we see that had ortho as kids that are having airway issues now, so many of them are class 2. Their mandibles are trapped back.
Yep.
Right. But it's all right, you know what? Let's get a straight arch. But they're retruding it. So I think there's so many different messages, in terms of looking at airway, looking at health, not doing IPR. I always show the bicuspid extraction cases, right? Because those are the ones that people are really seeing that are having problems.
Now, so when I go to a lunch and learn in an orthodontist's office, I find that, and maybe you feel this way too, they don't get the whole picture. They get a little bit of it, because I get a decent amount of referrals from orthodontists. I wouldn't call them all airway centric orthodontists, but they're making the referral to a myofunctional therapist. So there's something on their brain. But my favorite question is, they're like, listen, we want to send patients to you. Tell me exactly what patient I need to send. And I say to them, I'm like, literally anybody that comes into an orthodontist's office, Why are they in the chair? What went wrong? Somewhere the soft tissue dysfunction, whatever it is present. That's why they're here. So I tell them literally everybody that comes into an orthodontist's office needs a myofunctional therapy referral. So I don't know if you agree with that, disagree. Would you always recommend myofunctional therapy?
Absolutely. To that point, you know, when you see people with anterior open bite, it's a tongue thrust.
Mm-hmm.
It's not necessarily a tongue thrust. Either their tongue's going to fall back and close off their airway, or they're going to push their tongue forward because they want to stay alive.
Right.
So, and a lot of the people that are tongue-tied, that's what they're going to do.
Mm-hmm.
I think what's happening also in dentistry is a lot of dentists are getting sold lasers, right? I had a CO2 laser. The problem is, if it's not an infant and someone's doing a frenectomy, that person needs myofunctional therapy. And the analogy I always use is, if my sneakers were tied together for 5 years and someone clipped my shoelaces, I'd fall on my face.
Yep.
Right? So it's the same premise of someone that's tongue-tied needing the therapy prior. I need myofunctional therapy. I have a problem though. I have a high vaulted palate.
Mm-hmm.
I can't get my tongue to the roof of my mouth. So what did we do first? We did a Hyrex expander.
Mm-hmm.
I'm at a crossbite.
Mm-hmm.
I do my own exercises now,
Mm-hmm.
and then I'm going to need a frenectomy probably within the next 3 or 4 months because I'm a little bit tongue-tied.
Mm-hmm. Who's going to do that frenectomy for you?
Scott Siegel,
Yeah.
my buddy, the best.
I figured, but I wanted to ask anyways.
No, Scott's one of the kindest and
so
just
great.
an amazing guy and so supportive of kind of the whole mission. And, you know, he really gets it. And just besides him being an amazing, you know, clinician, he's just the sweetest guy.
Mm-hmm. And this is kind of something I always explain to people. When I have people that reach out to me that are interested in myofunctional therapy, I mean, a lot of them are hygienists that are interested in myo, and they ask me what courses to take, where should they start? And I'm like, listen, I'm not trying to tell you to subscribe to my podcast, but there are amazing guest speakers that I have on here that are willing to spend an hour with me free, give me their time, give me their brain, their education. I mean, everybody in this field is they just want to spread the awareness. Everybody, I feel like how you just described Dr. Siegel, I don't think there's one person that's been on my podcast, including yourself, that I wouldn't say the same thing about. The fact that you're willing to come on here, again, taking the time, might be your only day off of the week, and just sharing that knowledge, and it's free knowledge. So I'm always telling everybody, go listen to my podcast. I don't talk much. It's the other people talking. They're the ones sharing everything. But everybody in this field they're just amazing. Yeah.
And you know, meeting people like yourself and Lauren and Ben and Michael Gelb, for me, it's very passionate, mm-hmm. right? And I love being around that. And if you put me in a room, people are like, damn, that guy has a lot of energy and a lot of passion. Now, I was passionate about restorative dentistry at one point. But in 2018, I hated getting up every day. Mm-hmm. I was really like physically and mentally debilitated. Mm-hmm. And I was great at my job. Mm-hmm. I just really hated it. I think I hated it because I was spinning my wheels. Mm-hmm. Things were breaking down that I would mount cases. I would deprogram the patient. I would go through every step along the way, and I was still having things breaking down. And that's hard. It's hard when you're a perfectionist. So many dentists are perfectionists, mm-hmm. and we do it to ourselves. Mm-hmm. My friend's an orthopedic surgeon. You know how many hips he does that fail? An implant of ours fails. It's like someone shot us in the head and like we have to walk out the door. But it's true. And a mentor of mine said something great, because I'm still doing some veneer cases with him. He's a famous periodontist. And I put a lot of pressure on myself. I would do a wax up. I'm like, I don't know if I love the tissue. I don't know if and he's like, Layne, you can't be perfect every day. And he said it. He's like, guys hit 300 and they make it into the Hall of Fame.
Mm-hmm.
And they're perfect 1 out of 3 times. He's like, how do you expect? And dentists, we do that. We do a lot to ourselves. And I think we need to be better as a profession of, collaborating more with physicians. And I go to my physician's office, and I'm friends with my physician. I easily wait 30 to 45 minutes. In my old office, no one ever waited in the reception area. But if someone waited more than 2 minutes, I'd get a look and I'm like, wait, I don't understand. I was at my physician's office the other day. I waited 45 minutes.
So true.
Right? We spoil these people. And I loved spoiling those people because they were my family. That's what I miss the most in dentistry is the people.
Oh yeah.
I miss my patients were like my family. When I sold my practice, it was really hard. It was really challenging.
I can only imagine. I felt the same way when I left clinical hygiene. I was at the same dental office since I graduated hygiene school in 2011. And I was devastated. It was in my hometown. I mean, I went to school with either the patient or the patient's grandchild or niece or nephew. And even, your staff, when you're with the same people for that long, and it was that way at my office, I mean, they're still my family. They had been with me through some of the most difficult times in my life. So I totally get that. One last question I have for you. If you were to speak to a room of new dental graduates, what is like the number one advice you would give them?
Wow. I love this question because I was on a panel at the New York County Dental Society.
Oops, I lost you, I think.
So I love the question about new graduates. And I was on a panel of 5 dentists at the Greater New York, at the New York County Dental Society. And the other 4 dentists, I was the last to speak. The other 4 dentists were talking about their practices, how great it was, how many celebrities they treated. And when it got to me, I didn't even realize this, but I said, I'm not going to talk about myself like the other people. And then I was like, man, that probably didn't sound good. But I said, I'm going to tell you people 3 things. I said, the first thing is, my professor in dental school said it, you're going to make more money with your mouth than with your hands. So learn how to talk to people, get off your phones, and really communicate. Second, go buy the book by Dale Carnegie, How to Win Friends and Influence People, and live it. I said, the third thing is, I said, I think I'm the best dentist in the city. I said, not because I have the best skills, but I said, when someone sits in my chair, they know I truly care about them. And I think I could sit and talk about, well, go train an airway and go train with Coist or Pankey or Spear. I think 90% of your success is how you interact with people. And Sean Aker, who's a Harvard psychologist, has a great TED Talk, and he talks about that. Because you can learn that, right? You have it. Michael Gelb has it. You know it, right? Someone walks in a room, people kind of gravitate to you. They gravitate to Michael and Lauren and Ben. And I think new graduates need to definitely do continuing ed. It's hard though, right? It's really hard because the cost, right? My cousin just graduated dental school from Penn. He's in a substantial amount of debt. So for him to go to Dawson or Pankey or Spear or Coist, it's expensive. So I think people like yourselves are doing great things with podcasts because you could learn a lot from that, right? They don't have to go out to Seattle or Arizona and spend $5,000-$10,000. Right. I think there's a ton of continuing ed. I would have them focus on airway. I think there's so many great educators and so much material because I don't want dentists to make the mistakes I made. And I found out about it pretty late in my career. And I wish I would have known about it earlier, where I would have focused more on airway. I would have set up the cases so they didn't fail, and still done the cases though.
Absolutely. Thank you so much for everything that you shared, for being just the awesome person that you are. Like I said, the second that you started speaking at that dental meeting, I was like, I have to have him on the podcast. Like, your energy is so addicting. It's
I appreciate that.
So I'm a huge fan of you. So yeah, anything that you want to leave the listeners with, any last minute tidbits?
I think that what you do and what so many other people do is really incredible. And I know you were asking me questions, but why do you do the podcast? I'm going to ask you a question.
Yeah, absolutely. For that same reason, just to spread the awareness. I mean, it is so important. And my hopes when I started it, I do think it's mostly professionals that are listening. My hopes was that it would go more to the general public. I try to get it out there. I post, the links and everything, but people need to hear it because, and I'm sure you hear this so often, like, especially with adults, it's like they've struggled with these symptoms their whole lives. And they've always had this like feeling in their gut, like something's wrong, but like everybody keeps telling me I'm fine. Or, the parent that has that gut feeling like, okay, my child shouldn't be breathing like this. They shouldn't be sleeping like this. Why are they posturing like that? Just to be able to get that word out there, I think is so important. And especially like I said, I direct so many hygienists to this podcast, to Hallie Bulkin's podcast, because it's free education. Just literally what you said for people that maybe aren't in it 100% yet, where they want to dive in and spend thousands of dollars on their education, but everybody drives, everybody works out, hopefully throw on a podcast. I mean, what you can learn. And that's the other reason people also ask me, how do you make time, to do these podcasts? Like, you have a busy practice. Why wouldn't I? It's an hour that I get to sit here with you and learn from you. I mean, it's amazing.
So Hallie is part of our team, by the way. She's incredible. I've learned so much from her. And I trained with Sandra Coulson. So I actually trained in myofunctional therapy because I wanted to see what it was about.
Yep.
And to your point, I got interviewed to do a TEDx talk, which is, I hope I wasn't to do it. And I talk about in my interview that our society, we've normalized snoring, sleep apnea, and ADD and their treatments, right? Like, it's normal to sleep with a face mask or even a mouthpiece, or give every kid Ritalin and Adderall. And it's insane.
Yep. 1,000%. So yeah, I mean, just people like yourself sitting on here chatting, and, sometimes I'll ask other professionals if they have any questions for the person I'm interviewing, or parents and parent groups that I'm in. So I'm just thankful. I'm thankful for you, thankful for, everybody else like yourself that is just willing to come on here and chat with me, so that people know that snoring is not normal.
No. Yeah. And if you have any kid or adult that you're treating, or a friend and their son, and they're having like some issues, you can give them my email.
Perfect.
And they can send me some photos. And that's what we do a lot, right? I'll have, a friend's son being like, you know what, my son is snoring. And I'm like, all right, take a video of him sleeping and send it to me. And send me pictures of him, and I tell him even take teaspoons, because something simple like that. I was at dinner a couple of weeks ago. The woman's like, yeah, my son, is snoring and he's super hyper. I don't think he has an airway issue. I'm like, I'm telling you. And then she shows me his teeth, and his central incisors, primary, are touching. I said, I'm telling you guys, an airway issue. Yep. And I sent them to Barry Raphael, and Barry's like, wow, yeah, that kid has some issues, right? But they wouldn't have known. They were talking to me about it, and that's what I do. Everywhere I go, I tell people in a subtle way what I'm doing. The interesting thing is, I'm actually inventing a pillow for snoring that we're going direct to consumer, because snoring is the entry point, right? Yep. So many people don't know what an airway problem is or sleep apnea, but everyone knows snoring, right? So
I just started using Sleep Cycle again on my phone, and it's picking up. So I don't snore. My fiance snores. And my little Yorkie, my 10-pound Yorkie, that's whose snore that the Sleep Cycle keeps picking up. If it's not this cute little, and I shouldn't say cute little, because that's what people say, right, about their kids. Oh, it's so cute that they snore like that, or they are adorable however they're sleeping. And yeah, of course they're adorable. And here I am saying it about my dog, because he is adorable. But I'm like, oh my gosh, between the two of you, you all need sleep studies.
Yeah. And Is your fiance or your husband?
Fiance.
Fiance, fit guy?
Very. Yep. And
Yeah. So it's
he's
an anatomical problem.
class 2.
Yep.
Very receded chin, has to have the beard. If he didn't have the beard, you'd be able to tell. The beard hides it. He gets upset when I talk about this, but it's true. And I'm like, listen, we can do something about it. You know, he's missing. Nobody knows where one of his bicuspids went. When I cleaned his teeth for the first time, I said to him, you're missing a tooth. He goes, how do you know? I'm like, well, for one, I'm a dental hygienist and I'm in your mouth right now. I asked his mom, nobody knows if it never came in, if somebody took it out. It is strange because it's only one. It's not even just like both of the uppers are gone. But anyways, he snores. I think he has a deviated septum. Same thing with his brother. I'm going to have his brother listen to this podcast. I've been trying to get him to go for a sleep study. He knows he has a deviated septum. He has witnessed apneas and he's got all these other issues. And I'm like, listen, sleep is the most essential thing that you can give yourself. You have to sleep well and you're not. Yeah. So he's the other one I'm about to lie to soon and tell him that I spent all this crazy money to get him a sleep test and force him.
And that's so to me, I always say there's no such thing as benign snoring. Mm-hmm. So when we look at it, it is really multifactorial. You brought it up. It's nasal patency. Mm-hmm. Is it a crowded airway? Soft tissue? Is there redundant tissue there? Uvula, base of tongue, and then anatomy. For me, it was anatomy. I had bad ortho, right? High vaulted palate, significant crossbite, and my teeth are all worn down. So it doesn't take a rocket scientist to be like, all right, that guy has a problem. Because even when I went to my ENT, like one of my best friends in the ENT, I'm like, all right, I want you to teach me about noses. So obviously I could look at a septum if it's deviated, but I want to know about turbinates. Yep. I want to know about other things. The problem is, as dentist, I only looked at teeth. I never looked at soft tissue. My friend only looks at soft tissue, never looks at the teeth. So that's where medicine and dentistry, that's where we could really bridge the gap, because we could collaborate so well and really help it, because it's not just let's give someone an oral appliance and ortho or a CPAP, because if they don't have nasal patency, they're going to be struggling still.
1,000%. Yeah. Collaboration is definitely key for sure. Well, thank you, Dr. Layne, for coming on. This has been an absolute blast chatting. We're definitely going to have you on again. I'm going to already start thinking of what other questions I have for you. But thank you so much for taking the time out of your busy schedule. I really appreciate it.
Thanks for what you do.